Smoke inhalation. Smoke inhalation is the leading cause of death during fires. It causes three types of injuries: thermal injury to the upper airways, chemical injury to tracheobronchial tree, and systemic poisoning due to carbon monoxide and or cyanide. When a patient presents with smoke inhalation, approach as you would any ACLS situation, and remember your ABCs. This should only take a few seconds. Example: airway patent, patient spontaneously breathing and appears well perfused, versus patient stridorous with increased work of breathing and patient is flushed and diaphoretic. Intubation is indicated if any of the following are present: respiratory distress, hypoventilation, deep burns to the face or neck, and blistering or edema of the oropharynx. If the findings of the previous slide are absent, go ahead and examine the oropharynx. If there is erythema, take an awake look at the cords with the laryngoscope. Supraglottic edema or blistering is predictive of airway failure, if not secured. Airway edema usually appears within 24 hours, so consider serial exams. Patients who don't need intubation should get O2 at an FiO2 of 100%. This is to displace carbon monoxide and cyanide as much as to directly correct hypoxia. It is tissue hypoxia rather than hypoxemia that leads to death. Oxygen is in the blood, but it is not participating in metabolism with carbon monoxide present. Standard pulse oximeters don't distinguish oxyhemoglobin from carboxyhemoglobin. Send an ABG and take note of the oxygen saturation, carboxyhemoglobin concentration, and methemoglobin concentration. Standard lab studies should also be sent, as well as lactate levels, where available. Many fires result from drugs and or ethanol, so consider a toxicology screen. Targeted history and physical should be done next. Check for surface burns on the face and neck and black sputum, suggestive of thermal injury to upper airways. Wheezing, cough, and dyspnea suggest damage to bronchial mucosa. Bronchodilators may be helpful here. This typically appears 12 to 36 hours post-inhalation. Next, do a chest x-ray to assess for occult trauma and for evidence of aspiration. Lung opacification has a low sensitivity but a high specificity for severe lung injury. Presume carbon monoxide poisoning in all cases until excluded by normal carboxyhemoglobin. Classic symptoms of headache, dyspnea, and cherry red lips are not always present, and don't trust SpO2. Non-smokers have up to 3% carbon monoxide at base levels, and smokers have 10 to 15% carbon monoxide at base levels. Cyanide poisoning should be suspected in lactic acidosis. Declining PaCO2, think metabolism shut down. Decreased LOC, cardiac arrest, and decompensation. Cyanide treatment includes decontamination and antidotes, sodium thiosulfate plus hydroxycobalamin. Subsequent complications include airway necrosis and sloughing between days 3 to 4. ARDS may develop up to a week after severe inhalation injury. Despite the high initial mortality and complication rate, survival and prognosis are excellent with an appropriate management.